if I was sitting right in front of you. So unfortunately, some of the clinical things that we're going to do, we'll watch video and you'll watch me. Maybe I'll grab one of my kids and make them a patient. And we'll do all the practical things as best we can. And of course, as you know, we have our, let me go ahead and find that. We have in our Google Drive, you have all of the, let me pull that up. Okay, so here's the Google Drive, which you have access to. And in here we have different categories of all the different papers. We have references. In this references section, you'll also see that we have patient examination references. There are some tools in here that we'll go over today and make sure that you know they're here in case you have to access them. Things like how to examine a patient with a tremor, how to localize a lesion, evaluating patients with demyelinating disease. So there's lots of resources in here that you'll be able to utilize for as long as we have access to a Google Drive. And this is a document that I'll continue to organize and make available to you. And then also, you know that we have the Prezi presentations, and these also are ongoing and are changeable. So let's see. Okay, so I was listening to some music this morning, and I was listening to Tommy by The Who. And if you're not familiar with the Tommy rock opera, it's about a patient who can't hear, can't see, can't feel, or at least so everyone around him believes. Basically, we're dealing with differing levels of this type of problem in all of humanity. And every time a patient comes into you, they have some level of deficit, usually not to the extreme that Tommy had, where he couldn't see, feel, or hear, or communicate. But to varying degrees, we all have some dysfunction that may be the beginning of pathological disease that's progressive and worsening over the years. And it may be related to vascular issues. It may be related to damage to brain, to spinal cord, demyelinating disease, and of course we went through all of those, all of the differential that it takes to identify different types of neurological diseases. Remember, we talked about some of those things in the first weekend, and we'll review that as well. What I have on the screen now is a patient of mine, and of course, when you look at a static picture, it will not give you the same information as seeing someone in real life or dynamically in video. But if we just look at this patient and we observe what we can, and so here I've set it up that somebody lost sound. Just confirm if you can hear me. Hate to speak all this time and no one hear me.
It's still up, Mark.
Okay. So what do we see here? We can look at the ocular alignment, obviously. We can look at maybe the forehead here and identify if we see any imbalance in tone. And so if we look at the eyes, try to identify if you see an elevated eye. Try to identify if you see an intorted eye or an extorted eye, twisted eye. All of those cardinal signs of gaze that you're familiar with are, hold on one second. All right, so does it look like we do have an eye that's elevated? All right, if we're looking at this patient, I would think that the left eye appears a little more elevated than the right. And what about the torsion of the eyes? Does it look like one eye might be extorted? Looks like maybe her right eye, the superior pole of her right eye, looks a bit extorted. So you can see the line that my cursor is making here. And here is the elevated eye on this left side. And we talked about those ocular tilt reactions and how they occur and how they can be associated to the graviceptive pathways, being either at the pontomedullary region, like the vestibular nuclei being involved, or the midbrain, and so forth. So looking at those ocular skew reactions is important, and understanding how to localize where those lesions may be becomes the next step. But first, observing it obviously is very, very important. Okay, so as I pull back on the screen here, you're going to see that. All right. Go ahead and just put that patient now in the actual context of gravity. You can see the pictures in the background. Now, give you a little bit of understanding. We're dealing with a patient that had a very significant head tilt. And now when we look at the eyes with the head tilt in position, things look a little different. And so here we might think that the left eye is the low eye, okay, as compared to when we had the head tilt corrected. There was a difference there. So understanding that just because this eye is low when she presents to us in person, we have to take into consideration that she has a significant head tilt. And here I drew some lines and things that can help us kind of just tease out differences. So now when we look at it in context of gravity and being upright in gravity, we certainly see a head tilt, which gives the appearance of a low eye on the left. But in reality, when we drew the line across, we see that it was actually an elevated eye. And that would be appropriate with a head tilt. So as we have a tilt to the left in this patient, the left eye should elevate naturally. That's the normal reaction. And in an ocular tilt reaction, it would be the depressed eye. So again, just looking at things differently sometimes can give you different information. So what else can we see from this patient? Okay, the next thing we may look at is the nasal labial folds here. And you can see that those are not even either. And that gives us some information about potentially the facial nerve and facial tone. It can also give us some information about brain, because we know that when we see facial paresis and things of that nature, that can be related to the higher cortical centers as well. And even looking at the angle of her lips here, we see that, again, not even. So when we look at things statically, we can't get as much of an assessment as when we take that patient and see them in real life. But these are important things to be able to identify. This happens to be a patient of mine that has a movement disorder. She's got loss of dopaminergic neurons, which project through the nigrostriatal pathways from the substantia nigra in the midbrain up to the thalamus and then and the cortical brain. And when we lose those nigrostriatal pathways, we lose dopaminergic drive to the motor cortex, and we have a loss of ability to move. And so this patient has a diagnosis of Parkinson's disease. And this is one of the defining factors, is something called mask-like faces, where patients lose the expressiveness in their facial muscles due to the loss of that midline dopaminergic drive. So I thought I would start with that. And of course, there are many things associated with Parkinson's presentation. Other than looking at face, we can also look at gait. Remember, anything midline is going to be homologous. So things that are in the midline are born of the same neurology or the same embryology. And so not only do we see a loss of the ability to move facial muscles, but we see that throughout the entire axial skeleton, and we see stooped postures and festinating gait. And these are also, of course, tremor as well. These are all signs that might be more evident in a more advanced Parkinsonian patient. But what about in our general patient population? We see these same deficits at varying degrees. So we see forward posture as a very common finding in all of our patients, whether they've got a movement disorder or not. Obviously, as a movement disorder progresses, these symptoms and these presentations become more evident. But don't want you to miss that diagnosis if you have that in the office. This is another, let's see if I move these, I'll just move this over. This is another interesting presentation here. Once again, we can see that the ocular alignment is skewed. We've got an elevation of the left eye here, and a depression of the right. And of course, we don't know exactly which one it is. Let's go ahead and just run this here. And basically, this is called a cover-uncover test. And what we're looking for is to identify, I might have to close these, let's see. I don't think it will. So what we're looking for here is we're looking for the eye that's being covered is blocked of vision, obviously. When you don't have vision, the ocular musculature will tend to move the eye to its equilibrium position. And so here, this patient, when we cover the left eye, is unable to see out of that eye, so they have to use their right eye for vision. When we pull away the cover, we're going to see if that eye moves. So as we pull away the cover, look to see if the eye moves. Pull away the cover, look to see if the eye moves. So you can see that the right eye depresses and the left eye elevates. And I'll show you that again. All right, and so this is called cover-uncover, and it tells us that when we take away the cover, the eye was moving underneath its cover due to imbalanced tone in the eye muscles, and then that is corrected when the patient tries to visualize the target in front of them. So this tells us that we've got a vertical skew deviation in this particular patient, and it's related to depressors and elevators of the eye. And those muscles, we learned last week or last month that they are hardwired into the brain and cerebellum, and superior muscles, elevator of the eyes, are hardwired into the cerebellum on the same side, and the depressors are elevate or are connected on the other side. All right, so we watch this person's ability to pursue. You'll see here that we're looking at smooth pursuits and looking at the ability to depress the eyes and elevate the eyes. And we look for intorsions, extorsions, the ability to track, obviously. Here, checking the ability to track the eyes down and away. And so if there was a primary, muscle palsy in the eye, you wouldn't be able to track appropriately. So you always check for cardinal signs of gaze first, and then we look to see if, when we break vergence, which is what we're doing here, does the eye move? And so here's a video showing you what happens, and then again in motion you'll see that these movements are very, very subtle, but they will be localizing for imbalances in ocular alignment. Okay, here's a video electronystagmography recording showing a saccadic pursuit. This is an abnormal pursuit, and you can see on the bottom the graph is showing a sinusoidal waveform that is not clean or smooth, and that's because there are saccadic intrusions which are abnormal, and these are again findings of movement imbalance. And if we just break things down to be very, very simple in neurology, and we say when the patient tries to smoothly track their eyes, like if they try to touch their finger to their nose, dysmetria of movement can be very, very subtle, but it also can be localized. This is a patient with a cerebellar lesion, and they lost the ability to smoothly track. And we know that in cerebellar lesions, we are we're always looking at things in their homologous relationships. So if we look at midline cerebellar function, and we're going to go over cerebellum again on this weekend, but if we look at midline cerebellar function, we know that there are certain connections that are somatotopically, and we're losing some people's video. I'm just going to respond here because Brian says that his video is not responding. Let us know if it doesn't come back. So think of the midline cerebellum, right? That midline cerebellum, it is focused, or I think I'm losing FaceTime there. It's related to the midline structures of the body. So we think of the axial musculature, the proximal musculature of the axial spine, of the axial skeleton, as being related to the midline structures of the cerebellum. So if I check somebody's finger to nose test and they're very, very accurate, and then I say, well, they don't have a cerebellar lesion, then really we've only tested one portion of the cerebellum, right? So if we test the lateral aspects of the cerebellum out in the lateral hemispheres, that's where the hands are represented, and the shoulder, or not shoulder, but wrist joints and elbow joints. Those are more lateral. They're represented more laterally in the cerebellum, and so. Okay, so let me close down my FaceTime and see if that helps. So those lateral cerebellar tests, they don't give you good information about midline cerebellar tests. So we need to know how to assess midline cerebellum versus lateral cerebellum, and looking at eye movements is a great tool. looking at smooth pursuits and saccades, and we'll talk about those as well today.
Yeah, but I felt like it was a big waste of all of our time. That the people that set it up misled me to believing.
We can hear you guys unless you're on mute. Unless you want us to hear you. Are you trying to say something that we should hear?
Because I was very clear about what I wanted, what I expected, and I felt like it was trying to get more people to sign up for a meeting that.
Let's see. Okay.
Frankly.
So here we have
and I don't want to
our. Yeah, if somebody knows who's talking, see if we can get them on mute and let them know that.
Don't want any more contact with your company.
Does anybody know who that is?
No, but I'm going to mute everyone real quick.
Okay. I went and just highlighted our syllabus in Neurology 1. And I went through and I think we went over most of these things pretty well. I left transcendental degeneration, extrapyramidal systems, the basic ganglionic systems, and the cerebellum to go over again. Everything else I thought we hit pretty well last time. And then here we have our Neurology 2 section. And again, these will be the things that I'll talk about today and tomorrow, and I'll do my best to hit everything, although it may not all be in the organization that we have here. Let's just look at more of these videos and see where they go. Okay. Well, just to get back to our patient, I'll see if I can move these. Yeah. This is a slide that talks about how the basal ganglia initiates movement, or is involved with our ability to initiate movement. And so if we just look at the schematic here, basically what we have is we have a motor cortex that has to create the signal for us to create conscious or controlled movement. And in order to do that, it has to activate the thalamus. And the thalamus, in turn, reactivates the motor cortex. And this ability to activate the thalamus is gated by the basal ganglionic system. And that system is known in total as the basal ganglia, but each nuclei is individually known as the putamen. They don't list the caudate here, but the caudate and the putamen are typically listed together. And then there's the globus pallidus pars externus and the globus pallidus pars internus. And we'll talk about how these systems loop together. And then the subthalamic nucleus is also in play here. And how these systems allow us to create conscious or voluntary movement. And this whole system is driven by both dopamine and GABA. And I really like this this drawing here. I think it's out of Kandel and Schwartz. If I can just get it to the size I want. Basically, what we have here in this red arrow is a depiction of the motor cortices that initiate movement. When we want to make a movement, the motor cortex has to activate the caudate and putamen, and that's represented here. And this activation of the putamen is excitatory, and that's why it's in red. And then we get also some input from the substantia nigra, from the midbrain dopaminergic neurons. They also help regulate and activate the inhibition that comes from the putamen. So when we activate something that's an inhibitor, and you can see here in the gray that the the putamen, when it is activated, it will actively inhibit the globus pallidus pars internus and also the globus pallidus pars externus. These loops are really quite fascinating because they tell us really they illustrate one of the schemata of the nervous system that we need to know very well, because most of the patients that we deal with are dealing with, there's only a few different dysfunctions that we know of in the nervous system, one of them being a loss of inhibition or escape mechanisms. And that's what happens naturally when we try to move. We have to activate the globus, the caudate and putamen. That activation allows us to inhibit deeper structures like the globus pallidus pars internus. And naturally, when the globus pallidus pars internus is activating, or when it is excited, it inhibits the thalamus, okay, and also sends descending inhibitory influence over the lower brain, the lower gray matter structures. So when we have good functioning systems, our brain activates the caudate and putamen. The caudate putamen inhibits the globus pallidus. The globus pallidus is typically inhibiting the thalamus, but when we inhibit it, we get excitation, and then we get a thalamic drive to the brain to create a descending signal. So that's in normal function. This is allowing us to move. And that pathway is considered the direct pathway in these basal ganglionic systems. The indirect pathway tends to be the pathway which is typically dominating, and this indirect pathway allows us to keep our body quiet. And so when we activate this direct pathway, it ultimately leads to an activation of the thalamus, which creates activation in the motor cortices. And the indirect pathway is kind of the yin and the yang. The indirect pathway is always trying to inhibit movement. And it does that as we activate, right? We get tonic activation from brain. So everything above is always activating things below it. And it's either actively inhibiting or exciting. So here, when we get excitation from the motor cortex to the putamen, we also get an excitation of the putamen, which actively inhibits the globus pallidus pars externus. The globus pallidus pars externus is usually sending some inhibitory stimuli to the globus pallidus internus, but it's also strongly inhibiting the subthalamic nucleus. And this subthalamic nucleus likes to activate the internus, the globus pallidus pars internus, which is an inhibitor of the thalamus. So you could see that when we activate this indirect pathway, we're going to activate the globus pallidus pars externus, which likes to inhibit the subthalamic nucleus. The subthalamic nucleus is, in nature, is trying to activate the inhibitor of the thalamus. So these pathways are called basal ganglionic loops, and we'll talk about them in dysfunction as well, in conditions of hypo movement, like in a Parkinson's type disease. Now, when you see someone with Parkinson's and you see Michael J. Fox, and he has a tremor, most people think that's related to his Parkinson's disease, which it is, but it's a direct consequence of the medication that he's taking. It's not a consequence of the disease itself. Parkinson's is a disease of less movement, and so we get bradykinesia in Parkinson's. We get slowing of movement in Parkinson's, and it's only when we use medications do we get this rhythmic tremor that you see in a treated Parkinson's patient. If you don't treat a Parkinson's patient, you will end up with no movement at all, no facial movement, no movement of the physical body, and ultimately no movement of thought as well. This is a nice little video that talks about the cover-uncover test again, and it separates out phorias versus tropias, and tropias are static ocular alignment problems, and phorias have to do with vergence. So depending on how you do the cover-uncover, see how here he's creating a cover and then taking the cover away, and you can see that the hold on, there we go. You can see that when he takes the paddle away from the eyes and allows fovealization of both eyes, that's when we see the tropias, okay? And so we see that when we test the right eye, there's no problem. When we test the left eye, the eye moves. And so this indicates an imbalance in the lateral and medius rectus muscles. And we know from our studies last month that the vestibular nuclei are getting information from the inner ear and cerebellum and the neck afferents, and then creating activation of these oculomotor pathways. Okay, so basically what happens is when we cover the eye, this eye is normal, it's seeing, it's not moving, and then when we cover the other eye, we get the ocular deviation. So in this particular case, it's the left eye of the patient that is too far laterally. That's called an esotropia. I'm sorry, an exotropia. And if the eye is too medial, they call that an esotropia. And so what's important to know is that if there's no primary problem with the ocular muscles, which you could see there, that when they check cardinal signs of gaze with this patient, there's no loss of ocular movements. They're all normal. It's only when we test in cover-uncover that we bring these out. So these are going to be subtle findings in your patients that you're going to need to do these exams to identify them. And then we just have to identify which muscles are the ones that are dominating, because we know it's not a primary muscle problem because we tested cardinal signs of gaze, but we were able to test here during a cover-uncover test. We see no problem here. Here we see that the eye moves up when we make the cover. So again, that tells us that the right eye was too low to begin with. And when we covered the good left eye, the right eye moved into alignment so that that patient can see better. So that's a depression of that right eye. And then we just have to know, well, what muscles depress the right eye? Well, the superior oblique is a depressor. The inferior rectus is a depressor. And we can look at those and link them back to the neurological structures that innervate them. And if we can create constellations of findings and understand where these oculomotor findings lead us, then we can start to test other concomitant pathways. So if we think that we have a problem with a cranial nerve, like let's say the superior oblique muscle, and that's innervated by cranial nerve 4, and we know that cranial nerve 4 is in the pontine nuclei, then we can start to look at other pontine structures. If we think it's cranial nerve 3, and we know that's a mesencephalic nuclei, then we start to look at other mesencephalic structures and test those structures to start to try to localize findings. It's very important to understand that in neurology, there's very rarely isolated findings. So when we look at brainstem syndromes. We're looking for findings that localize us to the brainstem. So we're going to look at cranial nerve dysfunction, like we're seeing here potentially. But if there's a problem in that brainstem, in those neuronal pools in the brainstem, not only will we see dysfunction in a cranial nerve, but we'll also see dysfunction in the long tracts as well, right? So if we've got compression at the brainstem, whether it's from cerebral spinal fluid or related to some sort of derangement of the neural tissue inside whether it's coming from the brain being shifted, the brain, the hindbrain, the cerebellum, or from a hydrostatic pressure, then we're going to see signs and symptoms that correlate to things that live in that area. Okay, and so this is an important concept that if we see something local and localized and isolated, well, you might be dealing with a primary nerve lesion or a muscle paralysis. But when we start to see constellations of findings, like cranial nerve findings with contralateral long track signs, right? And this is a hallmark sign of brainstem syndromes. You'll get some ipsilateral loss of cranial nerve function or dysfunction of cranial nerve ipsilaterally. So let's say a cranial nerve 3 dysfunction, and I'll just stop the video here. Then we'd also see contralateral signs of the long tracks as well. So it's important to know those things when we look at our patients. So we need to have the mindset of, okay, when I evaluate my patient, I have to have the concept of, am I looking for a peripheral nerve deficit, or am I looking for a central neurological constellation of findings? And so there are oftentimes you'll see one finding, but if you don't correlate it with others from the region, you're not going to have the same success in localizing lesions. This is a patient that has an oculomotor dysfunction related to, I believe, a primary, let's see, probably told us what she had. Yeah, she had a finding or syndrome of oculomotor flutter, myoclonus, and axial ataxia. And so what I like about looking at syndromes is these are rare findings, right? So a patient with oculomotor flutter and myoclonus and ataxia of the trunk, you could see where she's lying. She's lying in a hospital bed, probably being seen by the greatest experts in the world on this particular issue. But in our patient population, these findings are there as well. They're just not fully realized yet, and they're not going to be ablative lesions. They're going to be what we consider soft lesions, where here you could see your finger to nose. You probably have patients that are similar to this. We have to take these findings as important, even though they're not fully realized dysfunction. So here, checking midline cerebellar function, checking heel to shin, and you can see she's more dysmetric with that right leg. She is not able to scrape the heel along the shin as well. And here, looking at her ability to walk, you can see she has very challenged gait. And so what's the significance here? The significance is that she has multiple findings in different systems, but when we trace them all back, we're looking at all midline structures of brain and nervous system. And so the ability to assess for these midline dysfunctions and understand where they come from becomes very, very important when we want to try and create some sort of intervention. Now, as cranial cervical junction experts, you're looking for cranial cervical junction dysfunction, and then ultimately you're going to apply your applications, and then you're going to have some responsibility to recheck these dysfunctions to see if the correction of the cranial cervical junction dysfunction was had an influence on these particular types of findings. All right, so understanding oculomotor function and understanding how these muscles work in conjunction is also really important, and you have all of this on your Prezi, so you can always go back and review this. If I could just move this. All right, we're familiar with the cranial nerves, right? 3, 4, 6, they are a homologous group. And understanding that the eyes do not sit perfectly in the sockets, focusing straight ahead, will help you understand the way these muscles move the eye. And we did talk about this a little bit last month, but it's good to review. Obviously, the medial and lateral rectus, those are pretty simple to understand their functions. They move the eye laterally and medially. And if you remember the formula LR6SO4, you probably won't forget which cranial nerve innervates which extraocular eye muscles. LR6, lateral rectus, is the 6th cranial nerve, and superior oblique is innervated by the 4th cranial nerve. All the others are innervated by cranial nerve 3, and they're all innervated by subset nuclei of cranial nerve 3. Cranial nerve 3 is a very, very complex cranial nerve. And then, of course, understanding the directions of these eye muscles becomes very important if you're going to use the oculomotor system to identify central neurological imbalances. And basically, you've got two sets of muscles here. You've got the recti muscles, and you have the oblique muscles. Okay, recti are a little more straightforward. Lateral rectus creates lateral movement of the eye, and the medial. Remember, we learned that the lateral rectus in the vestibulo-ocular reflex is the master, and the medial rectus was the slave. And remember, so the lateral rectus gets the innervation from the inner ear first. The superior and inferior rectus, they move the eyes up and out or down and out. And the superior oblique moves the eyes, the obliques move the eyes down and in and up and in. And the obliques are a bit reversed, and you're going to see why in a moment. You would think that the superior oblique might elevate the eye, but it's a depressor, and it also moves the eye towards the nose. And so if you see tonic deviation of these muscles, you're either dealing with an overactive muscle. So if I see the eye down into the nose compared to the other eye, well, then I'm either going to think that the muscle that moves the eye up and away is weak, or the muscle that moves the eye down and in is strong. That's always the case in neurology, especially in central neurological systems. We typically are dealing with loss of inhibition when we see dysfunction. So here's Fred. And sorry, Fred, I hope you take that in stride here. And this is a great illustration because it shows the eye in situ. We are on a chalkboard neurology, if you want to follow. Chalkboard neurology is the Prezi that we're using right now. So this is a superior view of the eye in its orbit. And you could see that the superior rectus, because of the 23-degree angle of the eye in the socket, the superior rectus is not situated parallel, let's say, to the sagittal plane of the individual. The superior rectus is innervated more medially, and then it inserts more, or I should say it originates more medially, and it inserts more laterally. And so you could see that when you activate that superior rectus muscle, that it would tend to pull the eye on a bit of an angled trajectory. So here are the eyes in the sockets. Again, this is that 23-degree angulation. Obviously, the orbital bones are the margins of the ocular orbit here. We've got the oculomotor nerve here. And then when we activate that superior oblique, we're going to see that we get a bit of a lateral movement as well of the eye. And here, these are the inferior obliques and the superior obliques now here in yellow. Okay, so when we bring the eye to the nose, this is a very important concept. When you bring the eye to the nose, we activate the medial rectus muscle to do that. Okay? When the eye is to the nose, if we were to activate the superior oblique, you'll see that the superior oblique becomes a strong depressor of the eye. If we were to activate the superior rectus, we're going to actually get intorsion of the eye. So depending on the primary position of the eye in the orbit, the muscles change their functions from primary to secondary to tertiary functions, and this gives us a window to be able to test if these systems are fully integrated or if there's dysfunction. Okay, so when we bring the eye, let's say, more laterally, let's see. Okay, we bring that eye more laterally. What does the superior rectus and superior oblique muscle do? They change their primary function. So let's just stop it here. Get that eye elevated. I'm sorry, laterally deviated. And then I want you to look at those muscles again. So that's the eye to the nose. And now that's the eye directed laterally. You can see when the pupil is this is the right eye looking from superior to inferior. You could see that when that right eye is deviated laterally, that the superior oblique muscle now becomes a very strong elevator of the eye. So if I were to contract the superior oblique muscle with the eye positioned more laterally, I'm going to get a greater ability to elevate the eye. So if you're checking your patients and checking their cardinal signs of gaze, and you have them deviate their eyes, let's say the right eye out to the right while they're following your large H. Let's just see if I can show myself again. Show bubbles. Yeah, okay, so you guys can see me? All right, so when I take my finger and I have the patient gaze and follow my finger, when I bring let's say when I bring the eye on the same side as my finger out laterally, and then I check for inferior and superior ability to move the eye, I'm checking that superior rectus muscle with the eye in the most advantageous position to see if that eye elevates and depresses cleanly. If I try to elevate the eye and it intorts, or I try to depress the eye and it intorts or extorts, it tells me that other muscles have a mechanical or are exerting their advantage over the superior and inferior erecti muscles, which should be elevating, depressing things because they have the advantage. due to the alignment of the extraocular eye muscle. If I don't see a clean movement and I see any type of torsion, it tells me that the superior oblique is weak. Not that the superior oblique itself is weak, but the innervation to it is not integrated as well as it should be. It's a very important point because we can use extraocular eye muscle function to identify if I've got central loss of integration. So I tested the eye muscles and I saw that they all worked in the cardinal signs of gaze. There's no primary muscle problem with the extraocular eye muscle itself. There's no comorbidities like thyroiditis or some other reason that the patient might have an oculomotor palsy. Then I'm looking at function. And when I put the eye muscles in their in certain positions, it gives me an ability to now assess if that muscle is doing its function fully integrated or not. Okay, same thing here. When I bring the eye to the nose, you would see if the ability to depress the eye was lost, well, then you know that you've lost superior oblique function. Okay, I have a question here. Let's see what this is. What do you refer? So someone asks me, what am I referring to when I talk about long track signs? So earlier when we spoke about brain stem, and let me just stop this for a second. When we spoke about brain stem syndromes, when we talk about brain stem syndromes, the brain stem is where the cranial nerves live. Okay, so if we've got a problem where the cranial nerves lives, you're going to expect that you have a focal loss of cranial nerve function. Oh, really? Oh. Let's take a small break because I think I have a water pipe that broke. Take a small break and we'll come back in just a few minutes here, okay? Let me put you guys on, how about a 10-minute break? All right, let's take a 10-minute break, then I'll answer those questions and we'll move forward from there, okay? 10-minute break. Why is the water on?